Well, until recently, V600E BRAF mutations were treated like any other lung cancer. Everything was lumped together. So those patients would have lacked a driver mutation, ALK, EGFR, ROS1, and they would have been treated with chemotherapy, usually a platinum-based chemotherapy. Most of those patients would be non-squamous tumors, so they'd probably get carboplatin pemetrexed in the United States. Some would use bevacizumab as well, but they certainly could get carboplatin paclitaxel or several other regimens, but they would have just gotten standard chemotherapy. Everyone's lumped together. In fact, still many of them still get frontline therapy with that, and people save specific therapy for V600E for the second line setting at this point. But now, with molecular testing, you can be more specific. You can give someone a drug that's going to work against a specific molecular driver, V600E, and spare them and have increased efficacy and spare them some of the toxicities associated with combination chemotherapy or even single agent chemotherapy.
In the BRAF V600E mutation, we have data for targeted therapy, but the question is, how do these patients behave on standard chemotherapy agents, which I think are the standard of care and have been the standard of care for quite some time. We don't have a wealth of data. The data that appears to be there suggests that these patients do behave typically as we've seen with chemotherapy in the past. So for instance, recent data looking at the V600E population in the second line setting suggested that they had a response rate to docetaxel of around 9%, progression-free survival time of around 2.5 to 3 months, which is kind of typical for the population. So I don't think there's anything prognostic about BRAF with regard to standard chemotherapy. And I assume that these patients get similar benefit from chemotherapy, so I generally recommend it as an option. But we clearly need more data in this setting to understand this a little better.
The current management of advanced non-small cell lung cancer is to characterize those for the oncogenic drivers for which we have targeted therapies. And at the current time, that's EGFR mutations, or you can give one of the EGFR tyrosine kinase inhibitors, the ALK rearrangements, for which there's 3 different ALK inhibitors that are approved, and for the ROS1 rearrangements where crizotinib is approved. For those patients who've had BRAF mutations where we have not had targeted therapy before, these are nearly all adenocarcinomas, and the standard therapy for all adenocarcinomas, which would include the BRAF mutants, has been pemetrexed and cisplatin. The outcome of patients with BRAF mutations who have been treated with chemotherapy have been compared to those with other oncogenic drivers and those that don't have an oncogenic driver. And they've been looked at in relatively large cohorts, both at our own institution, other places in the United States, and in Europe. It turns out the progression-free survival of the patients treated with chemotherapy who have a BRAF mutation is similar to those patients who don't have another oncogenic driver. So for instance, in the first-line setting, the progression-free survival of those patients is about 7 months. Now, in contrast, the progression-free survival of the patients who have either an EGFR mutation, an ALK rearrangement, is about 15 months. So it's about twice as long. In addition, the median survival where it's been looked at in the previously untreated patients is typical to what we see in an unselected patients, that is, in patients who do not have an EGFR mutation or an ALK or ROS1 rearrangement. So in the previously treated patients, that is typically those who've had cisplatin-based chemotherapy, there the progression-free survival is similar or perhaps a bit shorter than getting standard chemotherapy. The PFS of the BRAF mutants is typically somewhere around 1.5 to 3 months, whereas it's about 3 months for nearly all the other chemotherapy-treated patients. So therefore, the outcome of the BRAF mutants in the absence of targeted therapies appears to be similar to the patients who are ones who have not been selected for a driver mutation. So that is those patients who don't have an EGFR mutation or an ALK or ROS1 rearrangement.